So we will see now the use of transradial approach in the visceral intervention. And we have today the privilege to have with us Dr. Marcelo Guimarães from the University of South Carolina in Charleston. He has a huge experience in this area. So Marcelo, can you tell us what are the interests of transradial approach in the visceral interventions?
Dr. Fajita, thank you for your nice introduction. It's a privilege to be here. Thank you to Terumo for the opportunity to be part of the 30 years Terumo and Global Virtual Symposium. I think we have a couple of things that we can talk about on radio access. There's a lot of innovation in the last few years. If we Google or search online R2P, for example, which is a term coined by Terumo, we see 83,000 citations, right? If we look, for example, for Ravi radio, we have over 2 million citations. If you go a little further on radio access, specifically now on visceral interventions, which is what we do most of the time, we don't do cardiology procedures, we do peripheral procedures, including intervention and embolotherapy, we're talking about 1.3 million results. And it was a little disappointing when I looked for Ravi, that I saw a singer and not vascular interventional radiology data, but that's okay. That's a comment on the side. So if we look at the literature, the body of literature that has been built in the last few years, we have over 155 publications when we search for radio access in peripheral arterial disease. And if we look for radio access in embolotherapy in particular, we're looking at 223 results. So there is an exponential increase in the publications in the last few years to support to reflect what people are doing in terms of radio access. With the intention to provide standardized care on radio interventions and decrease the number of complications and empower people to build up successful radio access programs around the globe, we published this paper at the JVIR last year on the quality improvement standards on radio access. And I think this has been used now as a reference for best practices in radio access. Quickly review here, this is an interesting meta-analysis, a systemic review of radio access versus transfemoral in patients that underwent hepatic malignancy embolotherapy. And you can see here, meta-analysis of 9 comparative studies over 1,000 patients. The primary endpoint was patient satisfaction, and more than 85% of patients, so every 5 patients, 4 preferred radio access. That has been demonstrated in several publications. A little bit of a more longer procedure time at the beginning when there's a learning curve, but basically no difference if you compare radio versus femoral in terms of radiation exposure, in fluoro time, in contrast, and in complications. So why Ravi? Why radial artery access in visceral interventions? Basically, the patients can walk right after the case. The patients can sit up and be very comfortably in a recliner, for example. There's greater patient satisfaction documented in several studies. Shorter length of stay. Does not need to stop anticoagulation. We have publications showing that, the benefit. Does not need to transfuse blood products to correct if the patient has low platelets or high INR, for example. If there is any bleeding after you have the TR band applied in the patient's wrist, then those blood products can be given after the fact, but not upfront. So we save time and save cost in patients that have any coagulation issues. There are fewer access site complications, especially related to bleeding. And as we said at the beginning, mobility is allowed, which is something important for patients with chronic back pain, and give them access to the restroom right after the procedure. So we have been doing the radio access now for almost 10 years. And we have built along the way a couple of key items, and we call the 7 pillars for successful radio access. So let's break down a little bit on those 7 pillars. So first of all, we highly suggest every patient should have Barbeau test. There is recently some debate if we should do or not do. I think we should do. Every patient needs an oximetry pulse. It takes 30 seconds to do. And if you have Barbeau test done, that's going to give you peace of mind that patient in case there is radial artery occlusion during the procedure or after the procedure, that there's no risk of ischemia to the patient's hand. So Barbeau test A, B, or C will be good to go in the patients, and that doesn't take more than a few seconds. The second thing we do consistently is to check the AP diameter of the radial artery to make sure that the radial artery diameter is compatible with the outer diameter of the introducer sheath. For example, we've been using the 4-5 cylinder. And if the radial artery AP diameter is bigger than 1.6, we use that for embolotherapy. If we need to use a cylinder 6 French, for example, we need a radial artery diameter 2.4 millimeters. And we do that consistently in every single patient to make sure we're not going to have a complication. Again, this is another exam that takes less than 30 seconds, and we use ultrasound guidance in every single puncture. In relation to our setup, that's the setup that we have here in multiple pictures. You can see the video. We're working very comfortably behind a shield, like a door shield on wheels. So if you don't have that in particular, this can be done in a similar way with a shield, like a ceiling mounted shield in the skirt, and that will mimic what we have. The bottom line here is we measured in our prospective randomized clinical trial published back in 2017 that if the operator does this type of setup, either with the arm open 90 degrees or 45 degrees, there will be a 3-fold reduction in radiation exposure to the operator. And that's what we've been doing consistently in the last few years. We typically perform peripheral interventions. It can be PAD, it can be embolotherapy through the left radial artery. And there are 2 reasons why we do it that way. One, we want to try to avoid crossing the superior aortic vessels unnecessarily. That in theory could have increased risk of stroke. And the second thing is there is a waste of we lose about 10 centimeters, 4 inches from the right brachycephalic vein to the descending aorta versus left subclavian vein to the descending aorta. So that's why we do left side in most cases. But I have no hesitation to use the right radial artery in case the patient has a pathology on the right side of the chest, on the right side of the neck, for example. We recommend ultrasound guidance in every single procedure. I think is unacceptable. As you can see on this image here, this was a patient sent to us. And I took this picture on purpose to prove this is 2021 procedure. Right? This patient had 15 punctures before sent to us, failed the access in the radial artery. And then to us, this is unacceptable. So we use ultrasound guidance in 100% of cases using the radial kit that has a small needle. And after obtaining access, we always use some sort of a dressing to secure because the sheath is really hydrophilic. One important thing that I understand not everybody does, but I think we do in a consistent fashion, is to perform a forearm angiogram. Again, this does not take much time. We inject 4 or 5 cc's of contrast. And the reason why we do this is because I prefer to have an understanding of what I'm dealing with. For example, you can see here examples of a spasm of the radial artery. You can have another spasm a little lower in the left lower quadrant. You can see a kink in tortuoise of the radial artery. You can have a high takeoff of the radial artery. So those things that information would give me a precise information on how I will get access to this artery. That can be, for example, if there's a spasm, I'm going to get with microcatheter first, microwire, and then inject the vasodilator from the brachial artery. I'm not going to force that spasm. And typically the spasm goes away. If there's a tortuoise, I'm going to monitor the guide wire slowly and observing the movement inside the artery and making sure that tortuoise can straight up right after. So I will not give up on the access and change to femoral, but I will definitely be more careful and use the precise tool that can overcome that challenge. So this gives me peace of mind and increases safety throughout the procedure. For prevention of a spasm, we typically use nitroglycerin at the beginning and at the end of the case, and we use verapamil also in procedures that are long, and anytime we need to move the catheter from different spots. For example, PAE procedures, need to do bilateral infusion, uterine fiber embolization, bilateral infusion, PAD, if you need to move the catheter in exchange for long sheath. So we always use verapamil as well. Why do we use nitro at the end? We saw in our prospective randomized clinical trial that there is a spasm of the radial artery at the end of the case. We did a forearm angiogram at the beginning, in all patients in a forearm angiogram at the end, and we saw a spasm. So that's why we recommend nitro at the end. And of course, to prevent clot formation, we recommend heparin as well. And if the procedure takes longer than 30 minutes, every 30 minutes, we give 1,000 of heparin. A frequent question if it is possible or not to perform cone beam CT, rotational angiography during radio access. And it is super simple. Even though if you have the patient's arm open 90 degrees or 45, during the rotational angiography, as you can see on the screen here, we tuck the patient's arm against the torso, and then we're able to rotate the patient, do a cone beam CT, rotational angiography without any collision. Another important part of our technique is to use fluoroscopy for the entire time while you're advancing the wire and the catheter around the aortic arch. We just want to be playing safe in order to prevent any risk of having stroke. And at the end of the case, we use the patent hemostasis concept. These are a study that we did in volunteers. You can see the MRI on the left with the balloon compressing the artery. So in theory here, what I want to show in this picture is you want to compress the artery enough to have hemostasis, but not excessive compression, as you can see on the right side, on the MRI on the right side of the screen, where there's no signal on the radial artery because of excessive compression. So that fine line is obtained using the patent hemostasis concept, using the TR band that can be applied safely to obtain hemostasis at the end of the procedure. So in terms of few examples of what we've been doing the last few years, we've been using radio access and we have done thousands of cases at this point, using for chemoembolizations, for Y90 procedures, for blend embolizations, basically any liver-directed therapy. Typically, we use the radio kit, the 4-5 cylinder. More recently, we have worked with Terumo to develop the MG1 catheter that can get access into the celiac, SMA, or renals without any resistance. A hydrophilic coating catheter, 125 centimeters in length, associated with a 1.5 J glide wire, 0 to 35. And then coaxially, we go with a micro catheter plug rate. Typically, we use a 150. That covers all sorts of embolotherapy with 150. If we do pelvic embolization, such as in PAE, prostatic artery embolization, then it needs to go lower, typically 2.0 or to 1.9 French tip. And you could be using a 165 microcatheter in length, and then at the end, closure with a TR band. Here, an example of a technology we've been using, which is a fusion of image, is the MRA. You can see in orange is the MRA sequence that is fused with the patient's fluoroscopy, and then we can clearly see where the origin of the uterine artery is, and then navigate without using much radiation or much contrast, and navigate very carefully our MG2 catheter now, 135, for example. And typically, we use coaxially with a 150 microcatheter, using hydropearls for embolization, and then closing the case with a TR band. Let's move now from embolization therapy to PAD, peripheral arterial disease. This is a classic example of a patient that can benefit tremendously from radio access. You can see here the distance is about almost 4 inches between the skin and the common femoral artery. So super high risk of bleeding complications. So in this case, as you can see, and look at the CT now, a sequence of images showing how large this patient was with very tiny little arteries. We got access to the patient's left arm, left radial, which was a few millimeters under the skin, and then navigated all the way to the external iliac artery. You can see the lesion in the external iliac artery. As soon as we were able to cross the lesion, we came with a destination slender, the 6 French destination, pre-dilated with a metacross balloon, and then multiple stents can be used, for example, including the mesogyral self-expandable stents to treat that type of stenosis. So in terms of future developments, that's something that I think we have a little bit of time to debate. I strongly believe that the company should consider partnering with a radiology imaging company. There is more and more technology being developed in which the devices are going to be communicating, are going to be talking to the image, and then that will be helping with precision, with navigation. So that's an opportunity to have an integration between imaging and devices. The second thing, and I think the company has been working on this in the last few decades, is to have smaller and smaller profile devices, but with the caveat that needs to have similar performance. So making smaller and not having the same performance of bigger devices is not going to be helpful. And the last thing, we all know that in the United States, the cost of healthcare is becoming more and more and more a problem, and not only in the US, in the whole world. So I think there is an opportunity to consider more investing at the beginning of the healthcare process, which is prevention, and see what are the opportunities in terms of developing devices that can be helping patients or the population to develop better habits and prevent any injury or disease to be occurring in the future. In other words, focus on devices and technologies that can increase people wellness, bringing them solutions to have better life and less need of healthcare. I think that those are my comments, Dr. Fajadad, and I'd like to hear your thoughts.
Oh, thank you, Marcelo, for this exceptional and brilliant presentation. And really, I'm sure that this will open the eyes and many interventional cardiologists. I ask you, what are the limitation of the radial access in your practice? In other words, in how many percentage of cases do you use radial access for visceral intervention?
So specifically on visceral interventions, and I would say embolotherapy is the most common that we perform. I'm talking here about liver-directed therapy, UFE, PAE, GI bleeding, trauma, and embolotherapy. I would say that in my practice is 90% or more of my patients are getting access via radio access. So I think in terms of limitations, I think most of the technology that is important to perform successful and safe embolizations is there. And I'm talking about long catheters, wires, microcatheters, etc. The only limitation that I have today to not use radio access is whenever I need to use a large device, for example, a cover stent that requires for example, a 7-French sheath. I'm not going to use radio access. But those are rare cases that when we need to use a cover stent. Most of the embolization therapy or bleeding, for example, or pseudoaneurysm or aneurysm can be managed with liquid embolic agents or with coils, for example, today. So it's a very limited, the limitation, let's say, is very limited, let's say. The limitation is the number of cases that we require is very small. In terms of percentage, as I mentioned, for visceral interventions is the vast majority.
Oh, thank you. And I was impressed during your presentation by the setup of the cath lab room. The setup with this protection shield when you are working from the left side via the left radial access. You tell us that sometimes if there is a problem of the radial access, left radial access, because of spatial anatomy, for example, you can do the same procedure from the right?
Absolutely. Actually, we have a sequence of to follow in terms of access. That's a great question. We've typically preference would be left radial because of the reasons I explained, especially the one across superior aortic vessels unnecessarily. Then if that artery is not as small, in some patients, the radial artery is too small, it's not compatible with the device that we need to use, then we take a look at the ulnar on the left. Most of the case, the ulnar will be dominant, and then we use the ulnar on the left. If that's not the case, then we can have an option either to go for the right side or to go femoral access. So we have a sequence that we try to follow consistently in order to provide safe access.
And finally, you have a huge experience in this field. How do you see the future?
The future in radio specifically, I believe you're referring to future in radio. I think radio is going to grow. Yeah, just going to grow more and more. I think the the company is focused on developing smaller devices, again, with a similar performance as I mentioned before. It's just a matter of educating physicians, staff, administrators of the benefits of radio access. And I have no doubt that in the visceral intervention world, it's just going to grow globally more and more within the next decade.
Thank you very much, Marcelo Guimarães, for this clear and brilliant demonstration of the use of transradial approach in the visceral intervention. Thank you very much.
Thanks to you. Thanks to Terumo. And it was an honor to be part of this. Thank you.